Diabetic peripheral neuropathy is currently being diagnosed very late in the UK because we use insensitive measures of nerve damage in primary care. At the moment we use the 10-gram monofilament test, which is very crude and diagnoses the disease very late. And as a result, patients have a false sense of security. They think everything is perfect because it's negative. But actually, when it is positive, it's too late and the disease is irreversible. These patients then present to our diabetic foot clinics where their mortality rate is very high. Within 5 years, people with foot ulceration, diabetic people with foot ulceration, 50% mortality rate. So really we are missing the boat when we should be using sensitive measures to diagnose peripheral neuropathy in primary care in the UK. Screening should commence in type 2 patients at diagnosis and on an annual basis, and more frequently if you have major risk factors. In type 1 diabetes, screening for neuropathy should start 5 years after diagnosis. This is the ADA recommendation, I think, which is fair enough. So patients with type 2 diabetes already present with complications with neuropathy. Therefore, they need to be screened at least on an annual basis. In Sheffield, we took an interesting route, and that is patients are not having foot screening properly done in community. So what we decided to do was, in the community, when patients come to have their eye screening done with retinal photography, we take advantage of that when they have eye drops put in and they're sitting down doing nothing. We take the shoes and socks of a podiatrist, examines their feet. We use point-of-care devices. These are sophisticated equipments that are entirely objective and can measure nerve function accurately. And the devices we use are pseudoscan. It's a measure of pseudomotor function. It measures sweat function. And so it's a measure of small fiber function. We also use the DPN check. It's a handheld device. It measures nerve conduction velocity and also amplitude. And the device is a small device and we put it in the leg, and it measures sural sensory conduction velocity and amplitude accurately without the need to ask the patient anything. Within 3 minutes you get a figure. So using this combined pseudoscan and DPN check, we have a sensitivity of 94% to detect peripheral neuropathy accurately. And if you use the monofilament, the prevalence detection of diabetic peripheral neuropathy was 12%. But if you use these combined measures, you detect it in around 50%. So all these patients who have false sense of security actually can have early neuropathy. We then direct the patients that have very early neuropathy, i.e. normal monofilament, but subclinical neuropathy with these abnormal point-of-care device measures, are referred for intensification of glucose control, blood pressure, cholesterol, lifestyle intervention to try and reverse the neuropathy. And those with established neuropathy who can't feel the monofilament are referred for podiatry advice, footwear, and general diabetes foot care education. So this is, we hope to roll it out in Sheffield to include all centres, all centres where eye screening is done, and to try and see if it has an impact on admission rates for foot ulceration, etc., on outcomes. But I think if we don't do something like this, as we did with eye screening, everybody having retinal photography, it changed the outcome. Blindness as a result of diabetes is not now the commonest cause. In the old, I've always, since I was a junior doctor, I was told the commonest cause of blindness is diabetes. It's no longer the case because of excellent annual eye screening using retinal photography. We want to take that education and transfer to neuropathy. Yes, so the model we have is the patients come to have an annual eye screening. We catch them, we use these two devices, the pseudoscan and DPN check, and once using that we can identify early peripheral neuropathy. So this is the model, and it's going to hopefully go to the whole, to cover the whole of Sheffield. I think we do need more evidence base. We need to look at cost effectiveness. I mean, the devices are expensive, and we need to look at, are they cost effective? So economic modeling is important. We need to see if we detect neuropathy early, is it reversible? Can we reverse it? Otherwise, what's the point of diagnosing early neuropathy? Is there something we can do? Again, we need to do some work regarding that. We need to see if these point of care devices predict the development of clinical neuropathy down the line. So these are the three important questions we need to address over the next couple of years. And if we can show that we can do this, then a large-scale implementation would be inevitable in my opinion, but we need to answer these important questions.